I want to provide thanks to all of you for this rich and informative discussion. Before we conclude, I'd like to get your final thoughts, few minutes only, not a dissertation. Don't pretend you're Harry Urban, going to go on for a half hour, from each of you on exciting new developments in emerging agents. So I'm going to start with Dr. Fathi to discuss what's exciting him about immunotherapies like ADCs and BiTEs and things like that.
Just briefly, to answer your question, Harry, I think it's an exciting but early field. There is a whole host of targets that are potentially relevant in AML. The oldest targets are CD33 and maybe CD123. There's a range of antibodies, naked antibodies, antibody drug conjugates, novel bispecific agents, novel DARTs, CAR T therapies that are now actually looking at additional targets in addition to those that I mentioned, such as CD70. The CD47 naked antibody seems to have some legs, at least in combination with hypermethylating therapy, both in MDS and in AML. We'll see ultimately where that data settles, but it seems to have some promise potentially in patients who have P53 mutated AML. So I think the surface of the leukemic cell, as opposed to the alterations within it, may also potentially provide us with novel approaches to treatment in the years ahead.
Thank you. Mark, give us your thoughts about moving the second generation FLT3 inhibitors in combination with initial intensive chemotherapy.
Well, we still, actually, I mean, it's nice that we have lots of choices, but we really need to move into refining what we have and how to use them. Is there an advantage to using a more potent selective inhibitor up front and transitioning to a type 1? Is there a reason to be using maintenance FLT3 inhibitor after transplant, and in whom, and using MRD? So in other words, we actually have the drugs, I think. Now we have to learn how to use them. We have to kind of go back to good old-fashioned discipline and do very careful large-scale trials with very specific molecularly defined questions. So there's still lots of work to do, but progress is being made.
Dan, one of the most difficult subsets of patients to treat are those with TP53 mutated AML. Anything besides 10 days of decitabine out there?
Gosh, I hope so. But you're right. I mean, it's been a long, long time, and this is proven to be resistant or refractory to most of what we've thrown at it. I think there's some hope now. You know, APR-246 is something that we've seen several presentations on, a specific P53 directed therapy for patients with that horrible mutation, both in MDS and AML. You know, I think there's some real promise there. The biology of the way that drug works is really exciting and different, and I think we're all anxiously waiting to hear more. And then, you know, I think some of the stem cell directed therapies may have the ability to neutralize to some degree P53. You know, when you look at venetoclax combinations, response rates are, you know, in the 50% range. So, you know, lower than non-P53 positive patients probably, although statistically still haven't quite seen that. But certainly the response durations are not quite as long for sure with P53 positive patients. But, you know, venetoclax is still certainly an option to consider. And then other stem cell directed therapies, Amir mentioned magrolimab, a CD47 antibody that has some stem cell directed therapeutic potential, seems to maybe have some activity in the P53 positive subsets. So I think around the corner, I'm hopeful that this will be something that we can work on solving soon.
Thanks, Dan. And Gail, you get to talk about the hottest topic that we have right now on our inpatient service, and it's not COVID, it's CAR T cells. CAR T cells and AML, is there a future there?
Well, we want there to be a future there. So CAR T cells, you know, I think the appeal has been, hey, wait a minute, that's cured some people. So we have cures with CAR T cells. What can we do to move curative therapy to patients with myeloid disease, patients with AML. So we have our most powerful immunotherapy is transplant. We cure some patients with transplant, but transplant's a pain, and we don't cure a lot of patients with transplant. So what about CAR T cells? I think the land of the myeloid hasn't come to full bloom yet. I've been particularly interested, as you know, in looking at an allo CAR, so allogeneic CAR T cells. Definitely one of the glitches with CAR T cells, which is profound, is that the patient has to be able to hang out until the cells are manufactured, and they also may have some extensively beaten up cells that may or may not survive what's needed to do. Neither the patient nor the T cells may be adequate to get them to CAR T. We haven't had this available for younger patients. It's not worked in myeloid. So what about taking really robust, fantastic cells from somebody else, hitting the right target? We're looking at CD123, but as was already mentioned, there are numerous targets in AML. And what about having those cells eliminate the possibility for graft versus host disease? And we want to overcome issues of T cell persistence. But I think that would be a very hot topic for AML, with, I think, at least the allure of potential cure, since CAR T cells have cured other patients with other hematologic malignancies.
Well, thank you again. And thanks to our viewing audience. We hope you found this OncLive Peer Exchange discussion to be useful and informative.